record. And I'm just going to post. So as I said to Phil at the start, if I get you just to fill in the little contact form that I'll put into the chat here, if you put your details into the form, oh, I've done it again. If you put your details into the form, come on, Conor. Why is this so hard to do over time? Chat. Here we go. So there's just a link there in the chat box. You can click the link, it'll open up a contact form. Just enter in your details, your name and your email address. And we will then distribute this session to you via email. And you can look at it again, or you can pass it on to friends or colleagues who couldn't make it today. So, Sorcha, am I forgetting anything? I feel like I'm forgetting something. No.
No, that's it. Just the recording, and to make sure that people sign up to get the recording then once completed.
Yeah. Okay.
That's all good. Yeah.
So let's stop the share. Here we go. Okay, so this is my colleague James Ryan, as I said.
Yes.
James has been working with Firefly for the last. There's a few more people need to get in here, do I? No. Oh yeah, just before we start as well, we are open to questions. So any questions that you have, we're happy to field them. And Sorcha feels the same, I think. She's happy to field any questions that come up.
Yeah,
you could put the questions into the chat, or you can unmute yourself and let rip, and then just mute yourself again. And we'll take those questions as they come along. So, as I said, we're going to have a conversation with James, talk to him about the journey that he's taken from his previous career, which we will find out a little bit about, and his time through his undergraduate degree and finding employment or beginning to work with Firefly for clinic. So, the first thing that is interesting about James is that you had a career before you decided to pursue podiatry. What was that?
Indeed, I was in the Irish Army.
Okay, and how long were you in the army for?
Irish Army for 5 years. Laterally with the United Nations as well. So.
Okay, and while you were in the army, did you feel that did you think that you wanted to pursue a career in the kind of healthcare area at some stage?
Yeah, I had a bit of experience, I suppose, with healthcare professionals when I was in the Defence Forces in Ireland, and it inspired me to look further afield and see if there was anything in the realm of healthcare that I was interested in.
And what sort of introduction did you have to healthcare? What sort of professions were you dealing with in the army?
Physiotherapists, I suppose the equivalent of a GP and medic, so doctors, and then paramedics as well.
Okay, and when you were in the army, did you have opportunities to pursue a change of career, or how did you in that process?
So I suppose it was kind of through personal experience. I dealt with the medical field, which kind of inspired me to look at it for myself, my own professional development. So initially what I wanted to do was take a step back from the army, take a bit of a career break, which you can do after about 5 years, and try and pursue some sort of healthcare degree, I suppose, in that time off. And
what did you need to do? What were the kind of practical things that you needed to do in order to be able to go down that route?
I suppose I had to went for leave. I went through the army, and I started doing a part-time course in Ireland. So it's called the Access course, which allows you to apply for different universities across Ireland and the UK.
Okay.
And it's similar to the UCAS and the CAO model.
Okay. So in essence, you did your A levels again, or you did your leaving cert here in Ireland again.
Yeah, indeed.
And so you picked specific subjects, I suppose, that were relevant to the healthcare area.
To the healthcare field.
Sorry, Conor. There is a message there in chat from Anne. Sorry, I can't hear James. Is anyone else having issues hearing James? if you could let us know.
We'll get James to talk up.
Little letter.
Oh.
Reject my vote.
Okay, thanks.
So when you made applications through UCAS and the CAO, which is the Irish version of UCAS, what universities were you looking at, and had you made the decision then that podiatry was the route that you were going to go down?
I hadn't necessarily made a decision on where I wanted to go. I feel I wanted to practice it. So through the time that I was doing my access course, I managed to contact different professionals in different fields, so physiotherapy, occupational therapy, speech and language, and podiatry, and see how clinical practice works for them on a daily basis. So through that, I suppose I kind of honed in on podiatry, and I decided that this could be a course for me. And primarily, I focused on Galway. So Galway is the only place in Republic of Ireland that teaches podiatry, and Northern Ireland as well, and over in the UK as well.
Ultimately, you ended up in the National University of Ireland in Galway. What was your? How did you perceive podiatry when you began the course? What sort of employment did you think you were training for?
I suppose primarily what the college the course entailed in Ireland was a HSE model. So it's a HSE NHS kind of based model where you're looking at care of the at-risk limb. So predominantly diabetic wound care and the likes as well. And
when you began your undergraduate degree, you were given placements. You were put on placement.
Yeah.
In what sort of kind of environments were you in placement?
So the environments I was on placement with was all HSE based. So I was working in the likes of Merlin Park, which is on the west coast of Ireland, and Galway, that on a weekly basis. I also had a few different places throughout the country, which all kind of culminated in St. James's Hospital in Dublin. So I was working with the diabetic daycare centre there.
Okay, so primarily the at-risk foot.
At-risk foot, yeah, for the most part.
And working in multidisciplinary teams?
Yeah,
okay.
It's great exposure to an MDT.
Is that a kind of a positive environment to work in? Is there like a good positive vibe around it?
Yeah, I enjoyed it. I suppose there's so many different, there's a lot of areas that you can go into podiatry. So there was a bit of a limited scope in a way, but that was good environment.
So when you were studying in your undergraduate degree, were you exposed to the MSK side of things at any stage?
I was exposed to MSK, just I suppose bits and pieces. I would say that it wasn't predominantly MSK focused until I came into third year of my podiatry degree, out of a 4-year degree. So I had exposure to, funny enough, a previous Firefly employee, Adam McAvoy, who became a lecturer in NUIG towards the end of my college degree. And that's when we had our first full exposure to MSK, I suppose. So
before you had started studying podiatry, you were conscious that you needed to kind of create a network, or at least tap into a network of people who were kind of recognized within the industry. So you had touched base with Firefly foot and ankle clinics before you had begun your undergraduate degree? Yeah, so I suppose the headquarters for Firefly is predominantly in Sligo now, spread out all over the place, but that's the main HQ, and I got in touch with Martin, who's the medical director of Firefly here, and I see if I could shadow him or shadow one of the podiatrists we're here to see if we could gain a bit more insight into podiatry before we decided this is what I wanted to do. So did you have, and what we do in Firefly is our Firefly foot and ankle clinics are very MSK focused. So although we do perform routine care, we do see diabetic patients. A lot of it, the majority of our patients are MSK. It would be for the most part. So did you, from your experiences with Firefly, and what you knew about Firefly and the type of patients that we treat here, did you feel that didn't align completely with what you were learning in your undergraduate degree if the degree was HSE/NHS focused? I think just the patient scope was a little bit different. So primary focus, I suppose, for us as we were coming towards the end of our degree was the at-risk limb. Again, routine care is definitely a part of it. It's bread and butter for most podiatrists. So they were kind of the two areas that we were mainly focused in. We touched on pediatrics, we touched on MSK ever so slightly, but there was no grand scope, I suppose, and
the other areas you can go into after you finish up in the college degree and move out to the professional world.
So when the lecturer who specialised in MSK, Adam McElwain, was introduced to, or when you were introduced to him, I'd imagine that was kind of quite a revealing experience insofar as that it maybe formally, from an educational point of view, opens up the student base to another element of another aspect of podiatry.
Yeah, no, it absolutely did. Definitely, like, I suppose when I look at previous training in comparison to MSK, goal is always A to B. We're trying to get the patient from, you know, a state of tissue dysfunction or a state of poor wound healing to healed and happy. But again, with MSK, there's a lot more, I suppose, you can, a lot of paths you can take, I suppose, to get from that A to B.
Yeah. So, is there a significant difference in working in an MSK environment as opposed to working in an at-risk foot kind of environment?
Yeah, there's a lot more variables, I suppose, when you come down the road of MSK. So I suppose when you're looking at an MSK patient, there's a lot of different ways to achieve the goals of the patient. And again, the goals of the patient vary greatly in an MSK based patient in comparison to, say, someone who has an ulceration.
Yeah. This might be a stupid question because I'm not a podiatrist. Is it easier to treat the at-risk foot because you can identify more clearly where there's pain because there might be visual evidence of it, or the patient themselves might be aware of ulceration or potential ulceration, or is that in comparison to MSK, or is that?
It kind of, I suppose, at the end of the day, coming down to patient compliance. So, like, yes, absolutely, a wound is easier to treat than an MSK-based patient, because when you're interacting with an MSK patient, like, there's a lot of variables you need to take into consideration, the likes of, I suppose, activity modification, strengthening, stretching, footwear advice, and then you kind of go into the realms of over-the-counter orthotics, custom-made orthotics, ankle-foot orthotics. And it's not one size fits all kind of paradigm. So there's a lot of variation in each patient that comes in the door.
So tell us about your experiences when when you were finishing your undergraduate degree and you were gaining experience in places like St. James's Hospital in Dublin and Merlin Park in Galway. Did you begin to feel kind of comfortable in those HSE/NHS environments?
Yeah, very comfortable. Yeah.
And then when you finished your degree, because of the connection you made with Firefly Foot and Ankle Clinic, you began to work here with Firefly. So was that kind of, was there a steep learning curve then when you arrived into an organization like Firefly, and the ratio to diabetic patients to MSK patients changes from your perspective? So was there a steep learning curve then? Did you have to kind of start your learning all over again in relation to the prescription of custom-made foot orthotics and that kind of thing? Absolutely,
it was small fish, big pond, I think is the best way to say it. It was great. When I started off in Firefly, I was exposed to some really good, I'm still exposed to some really good podiatrists. But and that really did bring on my knowledge, I suppose, my knowledge base of orthotics, orthotic therapy, and how it's appropriately used. So it was still a lot of learning.
So when did you start working with Firefly?
I started working with Firefly in September 2021.
September 2021, and were you given a clinic room and a list of patients that were going to come into you, or what was the process? How did they onboard you?
I started off shadowing, so I was shadowing and interacting with patients on a daily basis. So I was following a podiatrist that was working in a clinic with me here, and I was watching how she operated, how she approached each patient. We broke down each patient afterwards, discussed why the treatment plan went that particular way. I was always encouraged to interact as well throughout the consultation and ask questions, suggest things that were kind of popping into my mind for potential treatment. So that was kind of how I was fostered into the team here, I suppose, and then it grew over time to a point where I was given my own patient cohort for MSK patients. Now, again, I touch on the likes of routine cares as well, and shockwave therapy, Swift therapy, and the likes. So that was all stuff that was put to the side, and then my MSK was fostered, I suppose, within the practice here.
And within Firefly, is there an opportunity or platform around which you can bounce ideas off maybe senior podiatrists, or if you see a complex patient or complex pathology, and you might have a strong understanding of what the challenges are for the patient, but you mightn't be 100% confident. How do you kind of communicate, or how do you kind of soundboard off other more senior podiatrists in the organisation?
Well, I suppose I have with any complex patients, if there's anyone that I'm uncertain of, I can help through a feeder, I suppose, feed through to a complex MSK clinic that I run with Martin, the medical director, every month. So the two of us meet on a monthly basis. We sit in and we do a joint consultation with multiple patients. And on top of that, I have access to Greg, who's lead clinical podiatrist here, and then there's Martin as well. So get in touch with them on a regular basis as well through WhatsApp, and have conversations about different patients. If there's anything that I'm uncertain of, or treatment plans that they think might be able to be optimized, I suppose, I definitely bounce off that.
And what about outside of Firefly, from a kind of upskilling point of view? Are there resources that you use? Are there people that you kind of tap into? Are there websites that you visit that you to kind of keep on top of things?
Yeah, I suppose work's kind of your oyster. Continuous professional development is kind of something that's really focused on in Ireland. I'm not sure how it is in the UK, but you need to credit yourself 200 hours a year of continuous professional development. So the likes of that can go down from reading papers yourself. You can, if you want to be cheeky and try and get away with listening to podcasts, you can listen to podcasts.
Do they not like the idea of CPD through podcasts?
I suppose it's just very grey area. But the likes of continuous professional development conferences. So a few months ago, I was working with a few podiatrists and physical therapists and physiotherapists down in Cork. So we met for a weekend, and we went through again orthotic therapy and different ways to approach patients on clinic. Conferences were great as well. And again, you build a bit of a network, I suppose, between yourself and other working professionals, which is important. I kind of found that even pre-graduation as well, that it really kind of stood to me that I made some professional links before I jumped out to the real world.
Yeah, so just going back to what you're talking about there, so prior to graduation, you had a number of potential job opportunities because of the networks that you created, or the network that you built. Is that fair to say?
Yeah, no, it is.
And were they? Did that offer you a selection of kind of environments, working environments that you could enter into?
Yeah, it did. Yeah. Again, you're looking at primarily there's a lot of opportunity for podiatrists at the minute and where they can work. Everyone seems to be looking for a podiatrist wherever you look, whether it's Dublin or Sydney or over the UK. So I was chatting with MSK podiatrists. I was, I suppose, other people's clinical practice, like for routine cares, and then as well the HSE was an opportunity for me as well. So,
what do you think the biggest challenges are as a podiatrist today?
That's not on the list. The biggest challenge is
is the
it's too much work.
Too much work.
Too many opportunities. No, I think for challenge-wise, trying to develop yourself after you finish up in college. So for me, it was how do I continue with my own professional development? So trying to make sure that you're not being a busy fool. So looking into areas that I'm interested in. So if there's anything in particular that's of interest to me, to read around it, try and build on my skill sets that I already have.
Yeah.
So sometimes there's a long list of things, and it's just about choice.
And what about further education, masters? Is that something that's on your agenda potentially?
It is, but I'd say it's over the horizon at the minute.
Okay.
I'm going to take a few years in clinical practice and kind of, I suppose, get my bearings here, and then we'll see.
Yeah. So was when you graduated and you moved into the professional world, did that happen with ease, or did you find it was a big learning curve to get up to speed? Like, did you feel that your undergraduate degree prepared you for the new world?
Imposter syndrome is the best way that I can answer that, but eventually that kind of fades over time as well.
Yeah.
I think there's no amount of preparation that you can do within an undergraduate degree course. That's my firm belief anyway at this stage. To kind of prepare you for the professional world.
Yeah.
But again, it's time under tension, and the knowledge is there. It might be way back in the recess of your mind, but if you can pull it out,
yeah,
you will. And again, you don't need to give, I suppose, when I'm looking at an animal scale perspective, the answer doesn't have to be in front of you there and then.
Yeah.
If you have a treatment plan, you can adapt as you move forward.
Yeah. Okay. If anybody has any questions for James in relation to that kind of progress from moving from university to the professional world, or one of the things that stood out for me about James is that he was so conscious around developing that network within the podiatry world to provide options for himself after graduation. So if you have any questions at all, you can put them into the chat, or you can ask them, just unmute yourself. But I would just remind you to fill in the little contact form there that's in the chat to capture your details, and we can, in essence, what you're doing is signing up to our mailing list, and you can take yourself off it at any stage. But we will distribute this session to you after this, and we will also have a little feedback form on the email, just so you can let us know if you thought the session was of value or not. So as I said earlier on, towards the end of the session, I'm going to demonstrate our 3D scanning app Fusion, just to give you an idea of some of the technology that's in the professional world at the moment. One of the things we didn't actually talk about, James, is like some of the kind of toys and tools that you use when you're in clinic. There are, would you say that there is more of a reliance on technology as time passes in the podiatry profession, as well as just mirroring the wider world?
Yeah, it's always developing. I suppose we're trying to, what I'm trying at the minute, what I've been exposed to recently in Firefly I never had access to when I was an undergraduate. At the minute, I'm using the likes of shockwave therapy for anything kind of more so kind of chronic conditions, so like chronic plantar fasciitis. If we're looking at the likes of verrucopedis, like if we're looking at verrucas, we're trying to treat them in different ways all the time. Now, it's not limited to Swift therapy, but it's something that we've gotten into the clinic in the last 4 months. Seen a lot of success with it.
Yeah.
Now, saying that all the other traditional methods as well are still used as well. It depends on what the patient wants.
Yeah.
So there's great exposure there.
Is there an element of training involved when you're using these technologies?
No, I suppose short equivalent of the short course, I suppose, in both, and I suppose the science behind it, and kind of move forward from there.
Do you do a lot of anatomy capture because of the nature of the clinic? So are you scanning? Are you passing Paris, full boxes?
Mention that. No, so I'm using predominantly scanning. So the scanning app that we have in Firefly, it's seamless. It's a lot cleaner than using Pastor Paris. Now, sometimes if it's needed, Pastor Paris is used, and it's still bread and butter as well for casting and scanning of orthotics. So it really just depends on the podiatrist.
What are the efficiencies of scanning a patient's foot using an iPad and a scanner in comparison to plaster of Paris?
Time management, I suppose, is the best. I think you're quite literally 5 minutes, and you captured both feet, and if you're taking into account rescanning once or twice to make sure that you get all the proper anatomy. Typically it's an awful lot shorter than that, and then it's kind of a stepwise approach with the order forms. So I have an order form on my iPad. We also have physical order forms, so I can choose between the two of them if needs be, if there's anything that needs to be adapted.
Okay. So James mentioned the order form there. So Firefly has quite an extensive order form, and for the uninitiated, it can look a little bit daunting. Is that fair to say?
Initially, yeah.
Yeah, and there's a lot of terms and terminology there. And one of the things Sorcha is going to do shortly is she will kind of break that down for you and talk about some of the terms and what they mean, just so you kind of have exposure to, that kind of the format or what you're facing when you're writing a prescription for custom-made foot orthotic. And the other thing to say, I suppose, in relation to prescription of custom-made foot orthoses is that different labs use different terminology to communicate the same concepts, I suppose. So, a lot of podiatrists will use different labs for different types of treating different types of pathologies. And you have to be able to, I suppose, negotiate a world of all these terms. And, as I said, where some of them mean the same thing, but they sound very different. Okay, so look, we might take, it's just 1/2 past, it's 11:31 there now. We might take a 60-second or a 2-minute break, let's say 2 minutes. And James will then present to you on his experiences in clinic, his kind of clinical workflows, some of the theories that he has bouncing around, that he draws on from time to time, not from time to time, all the time. And yeah, so look, we'll come back at 11:34 and James will join you. If you have any questions for James, you can get them in the chat or you can ask them when we return, but we will talk to you shortly. Thank you.
Okay, guys, how are we doing? So I'm just going to have a wee chat to you guys about what my day-to-day looks like in the clinic. And then after that, Sorcha and Conor are going to take over and they're going to talk to you about order forms and scanning and casting. So my day-to-day in clinic, it starts off with, I suppose, my clinical practice. I'm going to talk to you a little bit about common pathologies that I come across, some of the paradigms that we use as well in Firefly, and just, I suppose, a list of other paradigms that are available, and just a little bit about casting and scanning from my point of view. So I suppose the first thing is a patient history. So at Firefly, what we do is we send out a form for the patients to fill out before they even come in. So that kind of takes care of most of your closed questions that you might have for a patient. It talks about everything from medical history, relevant medications that the patient might be using at the time, and I suppose a kind of a detailed talk through about what's going on for that particular patient when we're talking about MSK-based pathologies. Then the other part of patient history, I suppose, is when the patient is in to you and you're a little bit educated about what's going on for the patient, is to sit them down and have a conversation. So you'd be surprised what you find through those conversations with the patient. Typically, there's a lot more than what the form has told you that meets the eye. And it's really valuable information when you're trying to develop a treatment plan for anyone that walks in the door. The next thing is anatomy. So it's probably drilled into you from day one. It should, I suppose, until you become a sentient version of Gray's Anatomy clinical textbook. Anatomy is always going to be really important. Whenever I'm, I suppose, 10 or 15 minutes spare throughout the day, I try to jump in and just tackle something that I haven't seen in a while, and run through some of the basics. It always helps me in my day-to-day clinical practices. And then when we're looking at patient goals, no two patients really are the same. So recently, in the last few months, I've had a number of different patients who have had very similar pathologies, but their goals are completely different. So, for instance, I had two patients with posterior tibial tendon dysfunction. One patient wanted to beat his marathon PB, so we were talking about how to get him from A to B, from an area of tissue dysfunction to an area of healing. I had another lady in, and she also had posterior tibial tendon dysfunction, and her goal was that she wanted to walk her daughter down the aisle in 12 months' time without the use of an ankle foot orthotic. So again, that will completely guide the way that your treatment plan develops over time. It's something, I suppose, that I always found, or that I found recently since I jumped into the professional stream, has been really helpful for my own clinical practice. And time management. So time management is another one. Again, time under tension will kind of give you a little bit of a bit of a grounding on how to run your clinical practice. I generally started off and I had a bit of a blueprint of how much time I wanted to spend on each aspect of the consultation. Other than a clinical blueprint, the likes of having a very well positioned clock behind the patient or watching the wrist, it does help just kind of keep track of everything that's going on around you. The next one is just note taking. So in note taking, it's there for, I suppose, three different things. It's there to protect the patient, it's there to protect you, but overall as well, if you have really good and concise notes, it helps develop the treatment plan over time and kind of optimize the treatment of any particular patient that walks into your clinic. So MSK paradigms. So it's not quite the theory of everything. Overall, the theory should be that we have no paradigm shift and that everyone can use the same to treat every patient that walks into the clinic. But we're not there, and I'd say we're a while off yet before something like that develops. So these are just a number of different paradigms that have developed over the last few years. Again, traditionally, you'll all probably be aware of root theory. Again, one for the history books, but it's just important, I suppose, to take note of root theory and how it developed and where it's brought us to today. And we look, there's a small list there, I suppose, of other theories that are used or can be used in clinical practice. So you have the sagittal plane facilitation theory, Kirby's model, the Fuller model, tissue stress model, and depth, and the list does go on. What I tend to use on clinic on a daily basis is the likes of the tissue stress model and the sagittal plane facilitation model. So tissue stress model, what we're looking at is we're looking at the kinetic forces that run through tissue and how if the tissue is pushed beyond, say, its bandwidth of what makes it functional, we can start to get regression and dysfunction. And if that isn't altered, then we have an issue, and that issue can be compounded over time and kind of snowballs out of control. So it's about grasping a bit of control over the stresses that are being applied to the tissue in that area. The other one that I use in clinic is the sagittal plane facilitation model. That's based around 3 different sites. You're looking at the rocker bottom of the calcaneum. You're looking at a minimum of 10-degree dorsiflexion between the tibia and the talus before heel off of the foot on the ground. And then you're also looking at the metatarsal phalangeal joint and the rocker bottom there and how it facilitates through the gait cycle. So I suppose the overall arching goal here is that whatever paradigms you do use when you're on clinic, all roads should lead to Rome. So as long as we get from A to B and patient is happy and we get from a state of dysfunction to healing, you're doing the right thing. Now, clinical tests. So clinical tests, this is just kind of a brief overview again of what I use to some extent on a daily basis in clinic. So whenever I'm running an MSK clinic, I'm looking at my non-weight bearing, weight bearing dynamic movements, but it's a tailor-made experience. So the way I like to look at each patient that comes in the door to me is it's kind of like a recipe. You're not going to have 2 recipes that are exactly the same. You know, traditionally, when I was in college, I was taught how to run through a particular criteria, tick all the boxes as you run through, but no patient is graded the same, and no condition is the same either. So the likes of non-weight bearing tests that I use on a regular basis, range of motion, small joints assessments, muscle power testing, and then we have the Faber test and leg length discrepancy. When I'm looking at weight bearing tests, again, you can just read them out there as well yourselves. Jack's test, supination resistance, foot posture index, which is quite handy as well when you're looking at the foot and how it sits in the ground, and then single limb balance as well. So I recently had a conversation with a physiotherapist. We were talking about runners and the patients that come into our clinic. And he's a strong believer in single limb balance tests for all the patients that come into the runners. And he reckons that if the patient isn't able to stand on one foot for more than 90 seconds without touching down on the other limb, that they shouldn't be running. That the intrinsic muscles there that are working aren't capable of adapting to the pressure over time. Which is just an interesting thought more than anything else. And then if we look at dynamic, we're looking at the likes of gait assessment, a knee to wall assessment, a squat test, and single leg calf raises. So all of these will, I suppose, give us clinical indications of if there's any issues with the soft tissue running up the posterior chain, how the foot moves across the ground, is there a difference between left and right? And then again, tailor-made experience. So you really make of what you bring into the clinic. And common pathologies that I come across on a regular basis. So I suppose this is one to kind of take note of as well. So severs is something that I've come across quite regularly since I started on Firefly. Typically, I've seen it in patients from the ages of 8 to about 14. Again, when we look at severs, there's a lot of, I suppose, when we look at the developmental milestones of a patient, a child that's come into the clinic, you're looking at the soft tissue and how it develops over time, if there's any impingements or anything like that, if the posterior chain is tight. And if we're aggravating that growth plate in the calcaneus, we can lead into a few problems. Typically, this pops up in kids who are very active. So regular, I suppose, story that I hear on a daily basis is a patient comes in, they're training anywhere between 4 and 6 days a week in multiple different teams, pain in the heel, and it's driving them absolutely mental. So what we want to try and do is we want to try and loosen up that posterior chain. Sometimes we use orthotic therapy as well. I normally go for an over-the-counter orthotic with a weak heat lift on it, and it normally works quite well. If we're looking at Achilles tendinopathy and tendonitis, again, it's another one that's rather common. It's common in all, I suppose, age groups, and more often than not, I come across it in runners. So you can start to catch, again, if there's any sort of soft tissue tightness, if there's any damage to the Achilles, it can run down the road of, I suppose, niggles, aches and pains, which develop into something that could be a little bit more serious over time. Typically, I'm looking at the likes of modification of activity levels and looking at what the person is wearing on their feet. Again, having a look at muscle strength, balance. Then typically what we're trying to do is, I suppose, offload that area and kind of, again, if it's not an acute flare-up, stretch it out and strengthen it. Plantar fasciitis is another very common one that I've come across. So again, you can get acute and chronic forms of plantar fasciitis. I had a patient in the other day who has had plantar fasciitis for the last 12 years on her report. And it's the start of a very interesting journey for her. So at the minute, what we're using the likes of a custom-made foot orthotic, because there is also a pes valgus foot type. To get a little bit of support in underneath the foot, raise up that heel a little bit. Again, we're trying to loosen up that posterior chain a wee bit, and we're looking at the likes of shockwave therapy as well, moving into the future if we don't get a resolution of the symptoms that we're experiencing at the minute. Morton's neuroma is another one that's rather common, more common in women than men. Unfortunately, again, victims of the fashion industry, anything with a closed toe box shoe type typically does present with Morton's neuroma type pain, and enlargement of the nerve bundles in between your metatarsals. It can be solved in many different ways, but typically what you're trying to do is you're trying to change the mechanics of the forefoot. I found that what's rather successful is the likes of an orthotic with met bar or met pad in the forefoot area to help display the digits. That tends to settle things down, Morton's neuroma rise. And then posterior tibial tendon dysfunction and adult flat foot is another thing that I've regularly come across. Typically what we're trying to do is we're trying to be minimally invasive here. More often than not, if it runs into an adult acquired flat foot and it's still flexible, we use the likes of an ankle foot orthotic. So what we use in Firefly is the Ritchie brace. That might be just glossed over later on, but again, kind of predominantly what we're trying to do is either custom-made foot orthotic, or even in some instances, activity modification, strengthening when appropriate, and an over-the-counter orthotic sometimes can help too. And the last thing I want to chat to you guys about, I suppose, is CAT scan scanning from my perspective. So what we have is the when and how. So again, what I try to do in Firefly here is I'm trying to do a graduated and conservative treatment plan unless the patient's goals impede on that. So if the patient feels that they need orthotics or they have particular goals they want to complete in a set amount of period of time, what we have to do is we need to kind of expedite that process. Typically what we're looking at is, first of all, footwear and activity modification, strengthening and stretching, as I already mentioned before. Then again, like Mo mentioned, custom-made or over-the-counter orthotics, custom-made foot orthotics, and ankle foot orthotics. So you just want to have a look at what, I suppose, the benefits of the intervention are going to achieve. So again, if we're looking at the likes of the tissue stress model, the zone of optimum stress, can we get that tissue into a bandwidth which is happy and healthy and it's not pushing it beyond what it's capable of? And then the likes of the scanning that you use for it. So again, traditionally in Firefly at the minute, I'm using the scanning app that we have, and for the most part, on top of that, I do cast on occasion, but I don't think I've seen a phone box since I graduated. Now, all of them are appropriate, but that's just what we use here at the minute. So I'm going to pass you guys on, unless anyone has any questions for me, or Conor comes to save me. So let's see if I can get out of that. Perfect. Okay. He's back. So there we go. Hold on. Does anyone have any questions, or I can pass you on? Keep the ball rolling.
Any questions at all?
Yeah, you talked about using a brace for pronated foot. Can we have a look and see what that is?
Brace, yes.
Do we have a brace?
I've got a brace.
Fantastic. Connor's not here.
Keep them entertained again.
That will be these, yeah. I don't have any party pieces. Conor will be back in a few seconds. But yeah, we do use a brace. Oh, here it is. There we go. So that's this is a Ritchie brace. This is something that we use here in if it's appropriate. This one here is with the Tamarack hinge. Now this is an over-the-counter version. But what you're looking at here is it actually actively dorsiflexes the foot. This is for the likes of someone with a drop foot. So again, I suppose the novelty of the Ritchie brace in comparison to other bracing therapies is it's actually rather slimlined. May not look it from here. but it's something that you can easily fit onto a patient. And again, with a pair of trousers, they're easily concealed. Sometimes that psychological element of wearing a brace is quite difficult for patients.
There's a rigid hinge.
That's a rigid one as well. So that's a rigid hinge brace there as well. Again, it depends on the pathology that you're dealing with. So the likes of someone with chronic ankle arthritis, a rigid hinge where that's fixed in one place is sometimes appropriate for the patient. But that's the kind of bracing that we use here at the minute.
Right.
I would say like the Ritchie brace AFO can really be a game changer for certain patients who may have had consultation with surgeons and who have been told that they're looking at like
Ankle fusions, yeah, or complete ankle reconstruction. Yeah, it's a very conservative method, I suppose. What we're trying to do, I suppose, is be as minimally invasive as we possibly can for the patient. So sometimes they can be quite appropriate, depending on.
But you see, like for pathologies like drop foot, we kind of see patients sometimes who are facing into like the idea of a fused ankle. They come in, they get fitted with the Ritchie brace, and like they walk out of the clinic like there's nothing wrong with them really. Like from a visual point of view, I suppose.
Yeah.
And it's look, I'm not a podiatrist, but it's one of the most powerful resources that I see us use on a regular basis. Any other questions? Anything at all? So look, we have Sorcha, you're there, right?
Yeah, I'm here, Conor. Thanks.
Do you want to go now, or do you want to go from? Do you want to take a break?
I'm good if everyone else is fine to go straight in. I need hosting, or if you can. Okay, thank you for that. So I'm just going to share my screen now.
So Sorcha is our client development lead. She's previously worked in Firefly's operations division, processing orders for custom-made foot orthosis, and working as part of our technical support team. So interacting with customers on a daily basis and having conversations with customers about the types of pathologies they're facing, and they have questions about the most appropriate prescription type, or the most appropriate design, or what materials should be used in a particular order in order to meet the patient's needs. And as she'll explain, there's a huge amount of options and choices and different materials and different shell materials that are at the disposal of a Firefly customer. And our technical support team are there to, the technical support team really need to know what all those options are, so they can, have conversations with the customer about what's most appropriate. And it is fair to say that the most experienced podiatrists that we have as customers, who could be working for the Ministry of Defence, seeing quite complex pathologies, or they could be working for Premier League football clubs or international rugby teams. These highly experienced podiatrists would rely on our technical support team almost more so than the inexperienced podiatrists, because I would imagine that the inexperienced podiatrist kind of feels that they might be afraid to ask what they might feel is like a silly question or a stupid question. But really there are no stupid questions, and without wanting to put on the hard sell with Firefly, but what we offer that's different to many of our competitors is that level of technical support for our customer. And so I'm trying to give you a little background of where Sorcha comes from. So she did all that for years. She's now works with new customers that we have in the onboarding process, and to make sure that they hit the ground running. And on that note, Sorcha, it's all yours.
Thanks a million, Conor, for that. Hi, everyone. Thanks for tuning in today. As Conor alluded to there, I am the Firefly client development lead. So I'm part of the onboarding process for new customers, or if there are new podiatrists in a clinic. So for instance, if one of you guys were to join a clinic that orders from Firefly next year, or when you finish, that this will be part of my job to go through things with you to make sure that you're comfortable as possible with our prescription, with our products and things like that. So as Conor said as well, I was the operations and technical support lead for a number of years, so I have extensive experience in the industry. But what I'm going to talk to you today about is our order form, and I'm going to break it down into sections, and I suppose to explain what's important, to explain our shell materials, our top cover materials, things like that, and what makes us different as Firefly. So okay, so when you've decided that you have a patient in front of you, you've done their biomechanical assessment, and you've decided that you are going to prescribe them orthotics, there are two considerations initially that you need to take into account. Those two considerations are: what are you trying to achieve, and what footwear type are we looking to fit these devices into? So they're really, really important pieces of information. So what are you hoping that the device does for the patient? And then being able to communicate that to the lab, that we're able to design the product to be able to meet your expectations and your patient's expectations as well. So our first section of our order form is patient information. So it's relatively self-explanatory, but I'll just go through some parts of it here that are really important. So obviously patient name is really important to have a reference. You see there is date of birth, footwear type, weight, and shoe size. I would put them sections as imperatives. And why I would say that is, when you have date of birth, you've weight, you've shoe size, you're getting a bit of an idea as to who the patient is behind the prescription, who the patient is behind the cast. Footwear type, then what type of devices we're trying to fit these, or what type of footwear, apologies, we're trying to fit these devices into. Date of birth will give us an insight as to how old or how young the patient is. If the patient is under 16 years of age, we automatically register them for what we call an outgrowth program, where there are discounts when their devices are outgrown. If the patient, we might see that the patient might be born in 1939, 1940, and the clinician has prescribed a polypropylene shell with a semi-rigid rigidity. We then have the ammunition to be able to ask the question of the clinician whether they think that patient who is very elderly would be able to tolerate that, because in most cases they will not. But without that date of birth information, we don't know to ask. So there's no such thing as having too much information. It's all about giving us as much information as possible to make the translation part more fluid, but also that the device is exactly as you expect. Weight plus the rigidity that you choose equals the shell thickness of the device. So we have a matrix for our shell materials, and I'll go through our shell materials later, but we have our matrix for our shell materials, and as long as we have the weight and the rigidity chosen, then we'll be able to come up with the shell thickness that will suit that patient. Shoe size then determines the top cover length and width. We would finish our covers to a standardized template. So it's not for Nikes or for Adidas or for Reeboks or Asics or anything like that. So just standardized. What we would say is, if you have a specific type of footwear that you want to fit the devices into, we usually would ask for a template of the removable liner, should there be a removable liner, so that we can accurately finish the device so that it can just be slipped into the patient's shoe on fitting. In most cases, because they are standardized templates and because there are so many different ranges of toe box shapes, we would suggest that you have a sharp scissors to hand in clinic to be able to cut and shape the top cover to fit into a specific toe box that the patient would arrive in the clinic for their fitting to. footwear type then gives us an idea, like I said, what type of footwear that you're trying to fit the devices into. So then we look at things like heel cup
Can I just
depth.
ask a question?
Sorry, Matthew. God, you frightened me there. Sorry. Yes, of course.
When we've been in MSK clinics,
Yeah,
we've been, well, people we're with and ourselves have been telling patients to change the orthotics to different shoes and to wear them all the time to get the best possible results.
yes.
So people don't wear the same shoes all the time, do they? They wear it different.
Exactly. And
different
that's where things like putting down in the footwear type, some people might put down various, so a various range of shoes. And in that case, then we would usually, I suppose, suggest going for something like a standard functional device, which I'll go through. And that's your kind of for everyday type of footwear, or for changing into different ranges of or styles of footwear. But yeah, no, I completely agree. Not everyone wears the same style of shoe all the time. But you might find that a person maybe wears work boots. They wear work boots. They're in work the majority of the time. They want the devices to be able to fit into their work boots. And if they fit into their trainers that they wear at the weekend, excellent, that's fantastic. And that's something that we then take into account. But really, I suppose we're looking at what they spend most time in. Then again, it kind of depends on the pathology as well. If it's a thing that you need something like a really deep heel cup, that's not going to fit into all footwear types. So there is a bit of give and take as well with what we can do in the design to be able to get the best outcomes for the patient, but the patient also needs to, in some cases, have to review their footwear style to be able to allow the product and the device to do what it's meant to do. So I know that is a conversation that most podiatrists will have with their patients about changing their footwear, especially if you see there might be someone excessively pronating and they need as much control in the rear foot as possible, but they always wear loafers. With a low heel cup, like with a low profile kind of shoe like that, we're not going to get the level of control that we need. So that's a conversation then between a podiatrist and a patient to say, okay, well, this is what you need. This is what you're wearing, and we might need to come up with a compromise in between. We mightn't get as much of a heel cup depth as we need, but at least we're doing kind of something towards that. And I think that that's really important about how you communicate with the patient as well, to explain the reasons behind you asking perhaps for them to alter their footwear type. Has that answered your question there, Matthew?
Yeah, that's fine.
Okay.
Thank you.
Okay, thanks a million. Yeah, okay, so so that's the footwear type. A lot of people will write down various. Some people won't write down anything, but just anything at all there gives us an idea as to what we're working with, how much room we're working with. You take into account additions and extensions, how thick they are. If we see that the patient is wearing brogues and you're looking for thick top covers with forefoot extensions or lesion cutouts that are going to be thick in the forefoot, then we would have a conversation over maybe taking down the thickness of it to maybe half thickness, or figuring out, well, what other type of footwear did the patient say that they wear predominantly, things like that. So that is that patient info part. So then the next consideration is whether you're looking for a functional device or a palliative device. And this is really important to be able to decide. So are you looking for a functional device to change the load going through the foot? And in this case, there must be movement in the foot for a functional device to work. So it must be mobile. If it's a stiff foot, that's a stiff kind of shape, that's where we're looking at a more palliative type device. It's to accommodate an arthritic, painful, kind of high risk foot. That's where we're looking at our diabetic tri-densities and our ORA soft mold devices, which we'll talk about just a little later. And in this case, there's little to no movement in the foot, and instead we must accommodate the shape. And this is materials like cushion cork and EVA, whereas the functional materials would be your traditional polypropylene, carbon fiber, thermoplastic, and Delrin. And I'll talk to you all about those as well. Okay, so choosing the device type. So after you fill out the patient's information, this would be the next part of the prescription. This is probably the most important part of the prescription, I would say, because this determines the entire device. So we have a catalog, but it's also on our website, default specs for each of these devices. So you'll see there are headings: functional, dress, sport, and mold, and specialized, sorry, as well. So we might just talk about functional, dress, and sport first. So functional, dress, and sport, they're all functional devices. They're all for if a patient has movement in their feet. They're kind of broken down really to the footwear type almost. Dress devices would be really narrow, low heel cups, really nice and slimline. They would normally be to 3/4 length. Sports devices then would be for trainers. They have a wider shell grind, and they have a sports grind, so it's a wider shell grind. It has a higher heel cup depth, so they're going to be wider. So a rule of thumb as well, the higher the heel cup, the wider the device, the lower the heel cup, the narrower the device. So if you ask for a high heel cup depth in a device, it's going to be wider. So that's just kind of something for you guys to know. So then the dress is really narrow, sport is relatively wide with a high heel cup, and functional is your in between. A functional device would come with a 12 to 14 mil heel cup depth. A dress device would come for a standard slimline would be 8 to 10 mil heel cup depth, and a sports device then is 16 mil heel cup depth. So that kind of makes it kind of understandable as to why a functional device will fit into a couple of different ranges and styles of footwear. So you'll see there under functional, we have standard and direct milled. So standard, the differences between those is actually the manufacturing process. So standard means it's vacuum formed. So it's vacuum formed polypropylene, vacuum formed performance RX, vacuum formed carbon fiber. They would be the options for vacuum formed polypropylene or vacuum formed functional devices. Then we have direct milled devices. It says polypropylene only, but we have polypropylene or Delrin, and I'll talk to you about those again later. But the main differences between them is the manufacturing process, whereby for any vacuum formed device, for every left and right scan, every left and right foot, a left and right MDF mold has to be made as a positive for that patient. So then the material that you've chosen, whether it be carbon fiber, polypropylene, performance RX, that then is heated and vacuum pressed onto the MDF mold positive. So obviously there's more wastage, there's more materials being used, whereby a direct milled manufacturing process is more cost effective due to the fact that it is actually milled from a polypropylene block of material, so there's much less wastage. It's a unitized device, which means that the heel lifts can be built into the actual shell itself, so there'll be less need for refurbishments because the rest of the heel lifts will be applied in EVA. It's very robust, it's nice and slimline, it's just it's a really nice material. So whenever you see direct milled, it's just the manufacturing process that's different. So there's direct milled functional, you have a direct milled dress, and you have a direct milled sport, so you can choose either of those. Then we're on to the women's dress devices. So you see there, there's standard slimline and low heel cup slimline. So they would be our most popular ladies dress devices. And the main differences between the two of them is standard slimline, like I said, is 8 to 10 mil heel cup depth. A low heel cup slimline is 4 to 6 mil heel cup depth. So it's for your really low profile kind of dress shoes, or loafers or brogues, things like that. You see there you have flat heel cup and Cobra devices. Flat heel cup is where there's a 0 mil heel cup, so there's no heel cup at all. It's just a sheet or a continuation of the sheet of material, whether that be carbon fiber or polypropylene, just as a flat bed underneath the patient's heel. So we can't apply postings in it, there's no heel cup in it, so it's more so kind of an arch support type product. If you were to contact and ask for a flat heel cup, I would probably try and suggest for you to go for a low heel cup slimline, even if the 4 mil you think might be too high, even if we brought it down to 2 mil, but at least there's something there. That's just kind of something that I always suggest, because the flat heel cup isn't going to do anything for the correction for the patient's foot. Cobra then devices, they have a hanger type of shape in the heel. So there's no heel cup in it. There is, we can't apply any rear foot postings in it as well. It's designed for 3 centimeters and above heels. The flat heel cup and the Cobra devices, they wouldn't be greatly popular. But we have to be able to, I suppose, prescribe them or supply them when they are prescribed. Then men's dress, then that's slightly wider than a women's dress, because in most cases your male foot would be wider than your lady's foot. And then sports devices then, so they're kind of for your trainers, things like that. So standard sport has a 16 mil heel cup. It has a full length, so it's the functional and dress devices are as default met length only, so they're 3/4 length only. Sports devices then per default in our lab catalog is full length. So our standard sport has a neoprene top cover to toes, so it's that wetsuit material. It's really durable and really cushioning, and that would be our lab standard for standard sports devices. You have your direct milled option there, and then low profile sport. So the main differences between the low profile sport and the standard sport is, instead of a 16 mil heel cup depth like a standard sport, the low profile has a 12 mil heel cup. So because we're taking down the heel cup by 4 mil, we're narrowing the device slightly as well, because the lower the heel cup, the narrower the device, the higher the heel cup, the wider the device. And that would be really good for cycling shoes, golf shoes, or your lower kind of your lower volume type of trainers. It also has a thinner top cover as well. So 3 mil neoprene would be the standard sport, and 1.5 mil puff, which is what we call EVA. So if you see puff anywhere on a Firefly orthoform, it's actually EVA. And it also comes with a 1.5 mil pour-on forefoot extension. So when you see pour-on anywhere, it's cushioning, or shock absorbing in an arch fill, but I'll go through that when I go down further. So it's not cushioning on the shell itself. It starts at the distal edge of the shell and it goes to toes, just for extra forefoot cushioning, just I suppose for impact. And that's where we come into our impact sports devices then. So our impact sports devices is for offering control with shock absorption. So it's for impactful activities. If your patient is a really keen runner, but you need that bit of shock absorption, that's where you go for your impact sport. The one thing to note with the impact sport, because we haven't come across it in any of the other devices yet, is that there's a pour-on fill. And what that means is underneath the shell is filled up with pour-on. And that's for shock absorption. So whenever you see a pour-on fill, it's for shock absorption. You'll see there with RF post and with dual density RF post. So what that means is, as default, it comes as a rounded heel, and underneath the heel then has that pour-on fill continued for ultimate shock absorption. So if you leave it as just the impact sport, with no kind of EVA or dual density EVA rear foot post, that offers the most shock absorption. If you tick EVA rear foot post, you're adding control into it. If you're ticking a dual density EVA rear foot post, you're offering not only control, but shock attenuation at heel strike as well. So dual density rear foot post is really good for runners with maybe shin splints, medial tibial stress syndrome, because on the outer aspect, it has a softer EVA, which dampens the impact on heel strike. And on the inside, then it has a harder EVA, which provides control at mid stance. So that's just something with the impact sports device to keep an eye on. But it also, with a fill, it will increase the bulk of the device. So it is that bulkier bit, that bit bulkier than the rest of the devices that we've come across so far. Our soccer sport device then is our only device that comes with a carbon fiber shell as default. And the reason for that is because the XT Sprint has that bit of flex in it. It doesn't take up as much room in the shoe as your polypropylene, so it's much lower profile. And it is really just nice and lightweight. So with the soccer sport, it has an hourglass grind as default in it, to be able to taper in almost the waist of the MLA to match against the and to fit into the patient's football boots, rugby boots, soccer boots, things like that. So that would have a 1.5 mil puff EVA top cover to toes. It would have a 1.5 mil Niplex forefoot extension to toes. And what Niplex is, or whenever you see Niplex, it means shock absorption. So that Impact Sports actually comes with a 1.5 mil Niplex bottom cover. So Niplex can be used as either a bottom cover or a mid layer, and it's for shock absorption. So obviously if your patient is wearing soccer boots, football boots, rugby boots, things like that, there is a lot of shock absorption required, or a level at least in the forefoot, because in most cases they're going to be running with the boots on and with the orthotic in them. So just for that extra bit of shock absorption there. And it has a 10 mil heel cup depth as well. So it's almost the heel cup depth of a standard slimline with an hourglass grind, and it's just really nice and low profile. All of our products up to now would usually come, bar soccer sport, would usually come with a semi-rigid polypropylene shell as default across the board. Now you can always change that yourself, that's no problem, but if you keep things blank, you're going to get exactly as our default in our lab catalog or on our website. Next, we're coming to our mold devices. So on the mold devices, our polypropylene shell would come as semi-flexible. And the reason why it would come as semi-flexible is because it has a pour-on fill. Whenever you're adding a fill, it increases the rigidity of the shell itself. So with a pour-on fill and a semi-flexible shell, you're kind of pushing the device towards your semi-rigid type of device. If you were to take semi-rigid and you add a pour-on fill, you're pushing the device towards a more rigid device. I usually would describe our mold devices as your halfway house between a functional and a palliative device. And these would usually come, so standard mold would usually come with a 1.5 mil Niplex bottom cover, remember, for shock absorption. It would come with a 3 mil EVA heel lift, or a puff EVA top cover. It would come as a rounded EVA, a rounded intrinsic post. So underneath the heel will be filled with pour-on for ultimate shock absorption. And basically it would be for your patients who are perhaps hypersensitive, they have beginning stages of rheumatoid arthritis, but they don't need something really soft yet. You're looking for something slightly controlling, but not too controlling either. So that's why it will be kind of your halfway house. So then our palliative accommodative devices like our diabetic device and our ORA soft mold device. So our ORA soft mold device is our softest device we have. It's prescribed for patients with hypersensitivity and rheumatoid arthritis because ORA is in the name. So it also could be prescribed for your elderly patients who perhaps have issues maybe in the forefoot, but you just want something softer in the heel, midfoot area to be able to tackle the forefoot issues. If a patient has callus or lesions that you want to offload, but you want to keep everything nice and soft, then like I said earlier, our 1939 to 1940 patient would probably need an ORA soft mold. Even the standard mold devices or the low profile mold devices would still probably be too controlling for them. They mightn't be able to tolerate the shell at all. Our diabetic tri-density devices then, they would be for your diabetic patients. They have an EVA fill. They would be very bulky. They have 3 mil plastozote combined with 3 mil pour-on top covers, and they have a 1.5 mil cork bottom cover. They are bulky because they're designed to fit into your diabetic shoe, really, and they're really good for if you require some offloading and things like that. Then we're on to our EVA device. So an EVA is kind of your functional shock absorbing controlling device. It's made from medium density EVA as standard, but you can ask for a lower density or a higher density EVA depending on what you're looking for the patient. Then you have UCB, so UCBL and Roberts Whitman. I kind of talk about them together because they kind of do very similar, I suppose, similar jobs. So our UCBL device is our most controlling device. It is for, if you have, in most common, our UCBL, Roberts Whitman and gait plates are most commonly prescribed for children. They can be prescribed for adults, there's no problem with that. But it's just something to take into account that they're mainly prescribed for children. UCBL device is our most controlling device. It has a 26 to 32 mil heel cup depth for ultimate control in the rear foot. It would be for your excessive overpronators. But just it's so controlling that, and you obviously need to take into account fitting into a shoe, that when I get a prescription, or when I was getting prescriptions with UCBL devices ticked, I would look up at the footwear type. What's the footwear type that we're trying to fit this device into? And if it's a thing they had, I suppose anything that I thought wasn't as, I suppose, appropriate. So anything low profile at all. Even some trainers wouldn't accommodate a 26 to 32 mil heel cup depth. So I would then contact them and say, okay, I see you have UCBL ticked here on the form. Would you consider changing that for a Roberts Whitman device? And the reason why I say that is Roberts Whitman device is a 16 mil heel cup depth instead of a 26 to 32. But what we lose out on the heel cup depth, we gain back in with a medial and a lateral flange. So in essence, it still has the same level of control 5 that we would need for someone who is an excessive overpronator or something like that. And with that, then we could go for a Roberts Whitman, which is much better tolerated than the UCBL device. A gait plate then, so you might see this in children, or you might see it in an adult. They might have it in both feet or might have it one over the other. A gait plate is essentially a standard functional device, but it has an extension of the shell either medially or laterally to be able to promote in-toeing or out-toeing. So you might see that you have a patient in and they are in-toeing. So you're looking to promote out-toeing as a result. In a lot of cases with the gait plates, you see that the patients might be wearing them for 3, 6, probably 6, 9, 12 months. And then they have improved greatly. And as a result, then we would actually grind off the extension, the gait plate extension, and what they'd be left with then is a standard functional device. So that's kind of a good way to kind of look at the gait plates. Shell properties then. So then we'll be looking at shell materials. So you'll see here you have polypropylene vacuum formed. You have direct milled polypropylene. So that's kind of the differences between the two. So you see there direct milled polypropylene. This here is where you could have your heel lift built in, whereas this has an EVA stabilizing post. And if you wanted a heel lift, that has to be put on top. Then we have Performance RX, which is a nylon reinforced thermoplastic. It's thinner and lighter than our carbon fiber shells, but there are limitations with it. We can't do any gait plates, we can't apply any dells or grooves, and we can't apply really deep heel cup depths with the Performance RX, but it is a really robust material. Next, then we have our carbon fiber shells. So XT Sprint and TL2100 are our carbon fiber offerings. So TL2100 then would be our true carbon fiber. It's a controlling high rigidity device. So I would suggest that unless you're looking for something that's really rigid, to maybe opt for an XT Sprint over the TL2100. But why I say that is TL2100 is only available in 2 shell thicknesses, which is 2.2 mil and 2.8 mil. And both of them are relatively stiff. So if you had perhaps a lighter patient, you might want to prescribe a TL2100 because there's no flex and the patient might need a bit of flex in the shell. And in that case, they might get intolerance issues. But there's absolutely no problem if it's a thing that you do end up prescribing something and the patient isn't getting on with them. There's no problem at all. We can remake due to intolerance if the patient cannot tolerate it. Then our XT Sprint is a carbon laminate. So it's not a true carbon fiber like our TL2100, but it's a carbon laminate, and it's our most popular carbon fiber shell. It's low profile, durable and long lasting, and we can apply a lot of the grooves and gels and things into it. It's lower profile than polypropylene, and because it has that bit of flex in it, that's why it's really good for runners or athletes, things like that. So that's why it's our default for our soccer sports device. And then we have Delrin. So Delrin then is a high tensile strength crystalline plastic. It's specifically designed, I suppose, for either heavier patients or patients who are carrying out heavy duty activities, such as maybe you might have a patient who's lifting really heavy in the gym. Delrin is approximately half the thickness of what you'd find from a polypropylene shell. If you had a patient who was 130 kilos and you wanted either semi-flexible, semi-rigid, or rigid for that patient, all we can give that patient is a 5 mil polypropylene shell because that is our maximum. So they mightn't feel all the benefits from it. So that's where we have Delrin as an alternative for those type of patients. The rest of the order form, after you choose your device type, the rest of the order form is like going a la carte. You can follow the suggestions that we have in our catalog or on our website for the specific device type that you've chosen, or you can completely go with whatever you're looking for yourself. So I've just gone through the shell materials, but one thing I missed out on there is we have a 3D printed option as well, and it's a PA11 sustainable material that's made from 100% renewable castor beans. So that is our 3D printed offering as well. I just don't have it here in my, this is an older order form that I have, so I just don't have it here in my optional specs. Rigidity then, so when I spoke about earlier about having your patient's weight, rigidity plus weight equals the shell thickness. In most cases, it's semi-rigid. Bar our mold devices, it's semi-flexible, but you can choose that yourself. You can choose whether you want a rigid, semi-rigid, or semi-flexible shell for your patient. But I suppose our kind of default would be semi-rigid mainly across the board, unless you're looking for your more palliative device. Fill materials then, that's when underneath the shell itself is filled up with a material. So it's going to add bulk to the device. Whenever you see pour on, you think cushioning, you think shock absorption. EVA then is used to kind of stiffen up the device a little bit. So EVA fill material will be present in your EVA device, and it will be present in your diabetic tri-density devices because they're more stiff devices. Cork fill isn't predominantly used because it's very rigid and it will increase the rigidity of the device significantly. And it's just not something that's regularly or widely used. Forefoot extension then. So this is not, I suppose, a mid layer. Forefoot extension is where the shell ends, the distal edge of the shell ends, and you can apply extra material either to the sulcus or to the toes. So sulcus kind of where your toes are just starting, and then toes the end of the toe. So we have things like pour-on Niplex, cushion cork, and puff. So pour-on Niplex would be your cushioning or your shock absorption. Cushion cork and puff would be your stiffening. You might have a patient who has perhaps lesions on their left foot. So you're looking for a lesion accommodation to with a cutout for second and third. Well, what you might want to do is balance that out on the right foot by adding a cork forefoot extension, just so that the patient has that proprioception. But that's kind of the main reason why we would see someone kind of stiffening up the forefoot, because really we probably don't want too much bulk there, depending on the footwear type. And then puff then is EVA, and that's just if you need to stiffen up the forefoot as well. And I suppose that would be used then if you're adding a an FHL accommodation or a functional hallux limited accommodation, which we'll speak about later, into the device. And you, because it's made from EVA material, that you want an EVA forefoot extension on the opposite foot if you wanted to balance them out. Top cover selections then, so that's from heel to either your mets, your sulcus, or your toes. So vinyl would be, vinyl and leather are very similar. Vinyl would be that kind of wipeable material. Leather, microsuede, and WSL carbon are our premium top covers. So they actually come with a surcharge for them because they are premium top covers. Leather is leather kind of everywhere you see it. Microsuede is our default for all of our ladies' dress devices. So there's not a surcharge on that if you choose a ladies' dress device. WSL carbon would be a WSL carbon would be, I suppose, a really durable material. It's mainly used as a bottom cover for our carbon fiber shells. So for our XT Sprint and TL 2100, we would usually apply a WSL carbon bottom cover, and you'll see that down here. And the reason for that is because it's a more durable material that over time, when a patient is wearing carbon fiber shells, they can actually get sharp at the distal edge, and they can tear through the bottom cover, which has absolutely no effect whatsoever on the functionality of the device. But aesthetically, it mightn't look the best. So WSL carbon then is what we'd usually put as a carbon fiber bottom cover, and that can still tear over time as well, but it's just more durable than what we'd normally put down as our vinyl. Neoprene then, that's that that wetsuit material. It's really cushioning, it's really durable. Plastizote then is, you've probably heard of Plastizote. It's kind of that kind of porous material. We also have an alternative called P-Cell, which is less porous and more durable than Plastizote. Puff then is EVA. Bamboulon is a material that's been specifically designed for patients with hypohidrosis. So it has antibacterial properties in the actual material itself. But one thing to note is that due to that, they will require a more frequent refurbishment than the rest of our top cover materials. So that's just something to note when prescribing Bamboulon material. Combined material width, that means basically you want to combine any of these materials with a layer of cushioning. So with the layer of cushioning, which means pour on either 1.5 mil or 3 mil. And it's just really important then to choose the length. For instance, if you wanted a standard functional device and you wanted it to toes, but you don't tick to toes, you're going to get it to mets because that's our default. And it's just something to keep in mind, to make sure that you tick length here under the top cover selection. Bottom covers then is, we would always apply a bottom cover for any of our devices that are sulcus length or to toes, so anything longer than a met length, to protect either the mid layer that might be added, because that will be exposed underneath, or perhaps additions and extensions that will be added, and it just increases the durability of the device as well, and the longevity of it. So Agoflex then is a really stiffening bottom cover that we would usually put on kind of flimsy top covers. Vinyl would be just a wipeable bottom cover. It's kind of our default, really. 1.5 puff is EVA. It's not regularly prescribed as a bottom cover to stiffen up, because usually if that's the case, they would add that as a top cover instead. Niplex is that shock absorbing material. Microsuede is a grippy material. There's no surcharge for microsuede or WSL carbon as bottom covers. It's just as top covers. So microsuede then is just a grippy material, and that's really thin. And WSL carbon then is prescribed for carbon fiber shells. So then we're on to the posting section. So we have lab valuation here. So what this means is, it's actually nothing to do with posting. What this means is that you want us to discuss the prescription with people. What I will say is, if you tick lab valuation, please tick at the bottom of the form. Please call me, just to make sure that it's not missed. In this instance, you would give us as much information on the form as possible as to what the pathology of the patient is, what you found in your biomechanical assessment. On the back of the form, we have a biomechanical assessment kind of information area to fill out, so that when we receive the order form, we have that information, then we contact you and we discuss the order. You see there we have posting to calc vertical and posting as neutral as they sit. So calc vertical means that you just want us to correct calc vertical. You don't want to apply any postings here. Measurements from vertical means that you want us to correct calc vertical, and then you want us to angle from the measurements from vertical. Angle the measurements that you've applied here from vertical. So from that reference point, you want us then to add the measurements. Neutral as they sit is that you don't want us to correct any of the cast that you might send in. You don't want us to correct it. In a lot of cases, you'll see the neutral as they sit for perhaps a rigid, stiff cavoid foot type, or a patient who maybe has hypersensitivity, where you've captured exactly as you need it, and you don't want the lab to, I suppose, add postings to then add more postings, if that makes sense. In theory, if you have a high arch cavoid foot type and you take calc vertical, what we're actually doing to get it to calc vertical is we're lowering the MLA. So then it's not a true representation of the patient's foot, and that's why I would say to keep it as neutral as they sit. Calc vertical then would be where we would add, I suppose, I actually have a, okay, so this here, so this is posting to vertical. So we will mark at the back of the cast these vertical lines. So it's not a great photo, but you'll see here, especially on this right foot here, we would have to add an EVA wedge here of a couple of degrees, probably maybe 3 degrees, to get this right foot to vertical. This left foot seems, now it might just be the angle, this left foot seems relatively at vertical, but this right foot here, we would have to add a bit of an EVA wedge there before we scan to correct it to vertical, so that the posting then that's applied in this area is applied from that measurement. If nothing was ticked here, I'll just let you know what our defaults are. If nothing was ticked here at all, our default is correct to calc vertical, extrinsic rear foot post, and balance the forefoot to the rear foot. That is exactly how we do it. So that's just something to kind of keep in mind or keep note of. The only difference between extrinsic and intrinsic, because all of our posting is always applied in the shell, the only difference between the two of them is that with extrinsic, it comes with an EVA stabilizing post. With intrinsic, it comes without. So I have an image here to show. So this is an intrinsic EVA. So if you tick intrinsic on our form, you will get this shape. If you tick extrinsic, you will get this shape plus an EVA stabilizing post. And that's just something to keep note of, because in most cases you do need that extra bit of support in the rear foot. Extrinsic, intrinsic, forefoot. So then the main reasons then why you'd see a forefoot post would be if or extrinsic to sulcus or to toes forefoot post would be if your patient has a true forefoot varus and you need the ground to meet the forefoot that little bit quicker. A skive then would be a Kirby skive, that I'm sure you all have heard of. It's a more kind of aggressive form of rear foot posting. So you'll see there you have varus posting, you have valgus posting, so lateral posting, and then you have a varus skive, so a medial skive, and that just shows the level of aggression that a skive gives over postings. So that's just a little illustration that might help you guys there. Then, one thing to note is that with skives, it has a knock-on effect to the heel cup depth. So, for instance, a 2 mil skive will require a minimum of a 14 mil heel cup depth. 3 mil skive will require a minimum of a 16 mil heel cup depth, and they go up in those increments to be able to match this. So 14 mil here requires a 2 mil, 3 mil, 4 mil, 5 mil, 6 mil. So that is that there. Then we're on to inversion and motion. Inversion and motion are not widely used. I think they're used by probably less than a handful of podiatrists, and it all depends on your school of podiatry, how you've learned about these additions and their applications. But they're only used by, I'd say, 3 or 4 podiatrists who had finished a long time ago. So inversion and eversion is kind of when you're inverting or everting the entire device. So you're not just bisecting the rear foot and adding postings, you're completely changing the angle of the whole device. And what can happen there is that if you go too high of an angle, the patient could feel like they're slipping off the device, either kind of outwards or inwards, depending on if you're inverting or everting. Motion then is where in that EVA stabilizing rear foot post, where the medial and the lateral sides are tapered so that when the device is put into the shoe, it promotes like a rocking motion. But in I suppose my experience, your orthotics goes into your shoe or your footwear, and that footwear acts as a buttress for your device, that there should not be kind of a promotion of rocking in that, but that's just something that you mightn't have come across before, the inversion of motion, but they're not widely used at all. So I'll just see here. Okay, cast dressings then. I'll try and wrap this up because I know Conor wants to get on as well. So cast dressings then is the distance between the orthotic and the patient's foot. So for instance, minimum is our default, so it allows a little bit of room. It's mainly it kind of is derived from the traditional manufacture of orthotics, where everything was manual and you would manually add plaster to the kind of plaster of Paris positive, to be able to, when you're, I suppose, pressing the material onto it, that there's that bit of room allowance. So moderate and maximum would be, I suppose, when you have to allow for maybe some tissue spread or lateral heel expansion, things like that. Type 1 or skin cast dressing then are when you just need a total contact insole, or minimum, I suppose, minimum space between it. So you want a really, really controlling device. One thing to note though is that if you're kind of going for a skin cast dressing, you might have intolerance issues. So minimum is our default, and a lot of people just leave it at that. So I've just kind of gone down through that quickly. Modifications then. So heel cup depths, first met, first ray cutouts. So these illustrations will show you kind of what's being done. So this is the first med cutout, that's the first ray cutout, rigid first extension. So if your patient has a functional hallux rigidus and you're trying to just splint up that area, so you don't want to promote movement, you could add a rigid first extension. So it's in shell modification, so it's of the shell, and that's either to sulcus or to toes. Medial flange, lateral flange for control. Narrow shell grind, wide shell grind, that's whether you want it tapered that bit narrower to maybe fit into a specific type of footwear, or if you need to widen, have a wider shell grind to I suppose improve the surface area. Facial accommodation then, that's where the fascia band is actually protruding from the patient's foot and you're looking to sit it into something soft. So what we would do is we would dell out and groove that area. We'd fill it with poron so that band, when it's coming out of the patient's foot, it's actually sitting onto poron, it's not hitting shell. And then your heel spur accommodation is if patient has a heel spur and you're delling out, so you're pushing out the shell material and you're filling that up with poron. Then a heel hold is very similar, whereas there's a hole in the heel and you can fill it up with silicone or with poron. Sweet spot then is where you have a bony prominence coming from the patient's foot. I suppose the most common areas would be the main areas would be your navicular, your medial cuneiform, your base of first met, base of fifth met, your styloid process, and your cuboid area. And what that means is the area is pushed out from the shell material and it's filled up with poron, so that bone is coming onto something nice and soft and not the shell. Additions then, I think that the illustrations there really speak for themselves. So Morton's extension would be similar to your rigid first extension, whereby it splints up the first. It only goes to sulcus as default, but you can ask for it to toes, and it's made from cork instead of the shell, which is sometimes more better tolerated. Reverse Morton's extension will be where there's material 2 to 5 to allow the first plantar flex. The FHL accommodation there is if you have limited movement. What we would do then, we would add a first med cutout just to promote movement in this area in the first. Now that's if there is limited range of motion in it. If there is no range of motion in it, that's where we splint it up. So you just need to kind of assess that, whether you want to splint it up or promote movement. Lesion accommodation then will be for calluses or corns. Horseshoe spur pad then would be kind of for if you had a heel spur to lift kind of this area. Met pads, met bar, met raise, they're all made from Poron, but they're just, I suppose, it's just kind of the width of them or the location of them. Poron arch pad would be extra kind of cushioning in your MLA area, perhaps for if you had a pes plano valgus foot type. Neuroma pad there is just you're lifting up the interdigits there between third and fourth usually. If you have bursitis, and cuboid pad is if you have a bit of cuboid pad or cuboid pain, patient had a bit of cuboid pain, and you just want to add a little cuboid pad there to cushion that out. So I'm just finishing there. Thank you all for listening, and I am happy to answer any questions any of you may have for me. Okay, thanks, Conor.
Thanks, Sorcha.
Thanks.
So there's a lot covered there, and it's an insight into the complexities of prescribing custom-made foot orthoses. As I said before Sorcha's presentation, that's why we have a team of technical support people who are at the end of the phone or at the end of an email to ask questions about appropriate device types, etc. So if you do have any questions for Sorcha, you can put them in the chat or you can ask them directly. But it is now 1:45. We're nearly there, we're nearly done. Thanks for sticking with us. What I'm going to do now for 10 minutes or so is just give you a quick overview of our scanning technology. And if you just bear with me for 1 second, I'm going to connect my iPad to Zoom. So what we're looking at here is, as James had said earlier on, traditionally patient anatomy was captured using plaster of Paris or foam boxes for semi-weight bearing, capturing anatomy in semi-weight bearing positions, but more and more often today, just a simple iPad with a scanner attached is becoming the most prevalent way for podiatrists to capture patient foot anatomy. And as James has said, the efficiencies are found in the speed and the time that it takes to capture a scan using the scanner and the Fusion app. You can capture your patient's feet in a matter of seconds. Whereas with plaster of Paris, it's going to take you at least 20 minutes to get the plaster on, wait for it to dry, clean up afterwards. And of course, you've got to stock the plaster. You've got to take the finished plaster and let it dry. You've got to package it up. You got to bring it to the post office. You got to cross your fingers that once it goes into the postal system, that it doesn't get it bashed around too much, and that it arrives to Firefly or the manufacturer in a reasonable condition. So we can then take a positive cast from the plaster of Paris and manufacture from that. So with scanning technology, you literally get your iPad out, scan your patient's feet, write your prescription within the app, hit submit, and it's gone. So you can see quite clearly how the efficiencies that the scanning technology offers. So let me just connect my iPad to Zoom here. Oh, Sorcha, you need to give me hosting back, I think. Or can I do it myself?
Sorry, Conor, 2 seconds now. I'll just go into that and give you your hosting back. Let me go. Oh. Sorry about that, Conor. Thanks.
Thank you. Okay, so you should be able to see my iPad screen. You should be able to. There we go. Okay, So when you log into Fusion, this is what you are met with. This is the Fusion dashboard. And the top of the dashboard gives you the battery status of the external third-party scanner, which is attached. It just attaches via a bracket. So the scanner is standard, but the bracket, you need to get the specific bracket to meet the needs of the iPad, so it can fit onto the iPad depending on what sort of iPad the practitioner is using. And people often ask us, why is the Fusion app not available on Android devices? And it's because we are reliant on a third-party scanning system that is not available for Android devices. And the reason that the structure sensor is used more commonly with iPads is because there is a limited number of iPads in comparison to the number of Android devices that are out there. So in order to get the geometry correct of the positioning of the scanner in relation to the camera on the iPad, the limited number of iPads in comparison to the many multiple different types of Android devices makes it easier to manufacture a smaller number of brackets that are appropriate for, or that are made for the scanner. So when you turn it on, this is what you're met with. The scanner battery status is in the top left. The iPad battery status is in the middle. You've got some notifications about your actions that you completed the app on the right-hand side. And below that, you've got your order history, which just details your patient names, the type of devices that you've ordered for those particular patients, when the devices were created. This gives you a date. And then there's various statuses for each of the orders. So an incomplete status means that the order has, the practitioner or the podiatrist has begun the order process, but they are missing something. They haven't completed the prescription, or they haven't captured all of the data or they haven't captured scans of the patient's feet. In review means that the order has been submitted to Firefly, to the lab. It's been successfully received by us, but we haven't begun manufacture. We're reviewing the order. Shipped means that it is being manufactured and it's been shipped. And submitted means that the order is in manufacture, in the process of manufacture. And the in review is kind of important as well, because frequently we will receive an order that will be reviewed by our technical support and operations team, and they might suggest on reviewing the order that maybe a more appropriate prescription, or the prescription needs to be tweaked in order to best meet the patient's needs. So there's two things happening. Obviously, the podiatrist needs to identify the pathology and create the prescription, but that is then kind of double checked within Firefly to make sure that, based on our experience, that it's the most appropriate device being manufactured for the patient's needs. And then there's other little efficiencies within the app, like you can reorder second sets directly from the dashboard. You can delete orders using the bin, or you can make changes to the orders by just tapping the pencil button. So very quickly, I'm just going to run you through the order process in the 9 minutes that I've left. I have a model foot here that will act as my piece of anatomy that I'm going to scan. You can stand up for me. There we go. So on the, actually, that's not a good idea. My phone. There you go. So on the left-hand side of the app, you can see that we have, it's our main navigation menu. We're currently in the dashboard. So if I tap the scanner button on the left, it'll open up the scanning element of the application and ask me to enter the patient's name. I'll put in my own name, Conor Lynch. Test Thursday, just so I can identify this order. So you put in your patient's name and you hit the set button, and immediately that ties this order, this particular order, to a patient. And if I stand up here, you can see there's a bounding box, two rectangles. The two rectangles reflect a three-dimensional space within which you want to place your target object. And in this instance, the target object is our patient's foot. And by kind of pinching the screen, I can make that target object, the target box, or the bounding box, I beg your pardon, bigger or smaller. So here's our patient's foot on the desk. And you can see there's different colors that are appearing there. So the blue tells me that I'm too close to the target object, the patient's foot. So if I move away slowly, I get that green rendering, and green is good. And if I move too far away, it'll turn red. So I'm going to move a little bit closer. And just get that green rendering. And once I see the green, so you want to be about half a meter away from the target object, which I am at. And then you just tap the scan button in the bottom right hand corner. Now before I scan, I'm just going to point out that by default, you begin in the left foot container, but if I want to scan a right foot only, I can just tap the right foot button and this will turn gray, which tells me that I'm in the right foot container. And then I just tap the scan button and very quickly, it'll start capturing the data of the target object and you just rotate around and you pick up that data, capture the data, and you can do this pretty quickly. And that looks good. You can see at the bottom of the screen, it's also giving me a reading of the distance that I am away from the target object. So 50 centimeters is good. Too close, it turns amber. Too far away, it turns amber. And then I just tap end scan on the bottom right hand side here. And it will automatically give me a preview. So actually, look, I'm missing a little bit of data there around the lateral malleoli. But for the most part, if I was going to manufacture, if I was scanning a patient's foot and this is for an orthotic device, I'd have a good, this would be a good scan. And I hit end preview at the bottom of the screen. The text has turned green for right foot and it automatically jumps me into the opposite foot container. So I'm going to scan the right foot again, but in the left foot container, but this is just for demonstration purposes. Quickly move around. So really the takeaway here is how quickly you can capture that patient anatomy in comparison to plaster of Paris. So that looks like a good scan. And preview. The next thing we do is we tap the order form button on the left hand side. We can see that the patient's name, Conor Lynch Test Thursday, has followed from the scanning elements. And there are a couple of crucial pieces of information that we have to enter into in order to submit the order. And they are, we have to put in a patient's weight, let's say 88 kg. We have to put in a shoe size, let's say 9.5. And that's it. So if, for example, I leave the patient's weight blank, you just get a little warning border around the area you need to put in the value. So the date of birth of the patient, their gender, the footwear that the device is going into is not required information, but we always say the more information you can provide in the prescription, the more accurate a device we can make to meet the patient's needs. So footwear will say, let's say tennis shoe. Okay, so we can progress through the order form. I'm going to do this very quickly. So this is just a digital representation or a digital version of the order form that Sorcha had discussed previously. Again, I'm met with a little kind of warning symbol here, a warning sign to say that the device type is a critical piece of information. So I said this is going into a tennis shoe, so I'm going to select a sports device. It gives me a second option. I'm going to say this is a nice, slim, low-profile device. It's a bilateral order. I captured the scan for the left and the right foot, even though I only had one foot, but you know what I mean. I'm going to tap the next button. I need to pick a shell material. I'm going to make this a carbon fiber, so I'm going to choose one of our carbon fiber materials, such as XT Sprint. Semi-rigid, there's no fills, there's no forefoot extension. And from here on in, you can get as detailed or specific with the order as you like, selecting all the different additions and modifications that we offer. And I won't go into them in any detail here, but you can see the order form is just a series of drop-down menus. If I want to put in a med pad on the left foot, standard med pad. And if I want to put in a different type of med pad on the opposite foot, just tap the plus button on the right-hand side. Your kind of accordion opens up on the opposite foot, and I'll put a full med pad on the right foot, and I'll just touch anywhere else on the screen, and that will close up again. I know that I've got two different values for this med pad element because the plus sign remains, and I'll keep progressing through the order form quite quickly. Yeah. So this is the order summary. This is our last piece before we submit the order. We've got a text box here. We can put in any additional instructions. For example, if we've got a tight turnaround time, if we've a patient who's leaving the country or they need the device by a particular date, I can put that information in there. And the operations team at Firefly will feed back to the podiatrist to tell them whether that date is achievable or not. But generally, we've got a 10 to 12 day turnaround time at the moment. And I'll just hit next. The penultimate page just gives you a textual overview of your order. Not very pretty, but it just kind of gives you a printout of what you have, what you've selected in the order. On the very last page, I tap next, is our shipping details. So this determines where the device is going to be sent to, and by default, more often than not, it goes to the postal address, the clinical postal address for the customer, or it could go to the patient address if post patient is selected on the very first page here, or you can send it anywhere else in the world by selecting this column and entering in the address. But that's it. So the last thing to do is to submit your order. You just hit submit. It tells you that the order is sent. Order submit successful. Hit continue. Order sent. And then you just need to find it. Here it is here. Order number 56785. It's a low profile sport device ordered today. It's been received by the lab. It's in review, so they're now looking at it to see if the prescription is appropriate and if it meets their kind of quality assessment. And that's it. So you can see how simple, how fast you can submit an order in comparison to more traditional means. And look, there's some podiatrists who love casting their patients. They see it as something of an art form, and they're reluctant to use scanning technology. But as we see more and more students graduate, apps like the Fusion app is becoming the kind of go-to standard for capturing anatomy, and I can only see that increasing over time. And the last thing to say that is the scanning technology, or using scanning technology like Fusion, is not always the most appropriate way to capture anatomy. If it is a particularly complex pathology, the podiatrist will still probably want to use plaster of Paris, because they will be able to control the positioning of the patient's foot. And the positioning of the foot is a common question that's asked in relation to scanning using the iPad and Fusion. How do you position the patient's foot? We've got some videos on our website about that. And the podiatrist needs to manipulate the foot into a fairly kind of right angle position. The foot is at a right angle to the leg, and the knee can be positioned on the edge of a chair or on a plinth, and the scan can take place when the patient is positioned in that way, or they can be in a prone position with their foot hanging over the edge of the plinth, and they can be scanned that way. But if the patient can hold the foot in a right degree, at a right degree angle, it's usually more. The scan is usually more than suitable for manufacture of custom-made for orthosis. So happy to take any questions that people might have on the Fusion app. You can download it from the App Store, and you can have a look around if you want. If you want to place an order, you need to have a Firefly account open, but you can still go into the app. You can download it. You can have a look you can enter the app by using the guest mode button down here. So you don't need to enter in your username and password if you don't have one. But guest mode will just give you an overview of what the app looks like, and you can look at the order form and get a feel for how it works without actually submitting any orders. And that's it. Happy to answer any questions that anybody might have. We're at 2 minutes past 1 o'clock, 3 minutes past 1 o'clock. Hopefully we get to do these visits in person in the years to come, although there's a lot to be said doing virtually. We can get in touch with a lot of undergraduate students quite easily from the northwest coast of Ireland here, and communicate with you on the south coast of England on this Thursday morning, Thursday afternoon at this stage. So look, if there's no questions, I will say thank you to Sorcha for helping us today. Oh, we've got something in the chat. This is exciting. 2 chats. Thank you.
Can I just ask a question, Conor, about the positioning of the foot using the methods that you spoke of?
Yeah.
Is that kind of supposed to hopefully have the subtalar joint in the neutral position when people do that?
Yes. Yes is the simple answer to that. That's what's trying to be achieved. There's the positioning of the opposite foot. Like if you have a patient prone on a plinth, the opposite foot can be kind of put across the foot that's being scanned. I'm not explaining this very well, but the foot that is being scanned should then fall into the appropriate position. And I'll tell you what I'll do. In my follow-up email to students, I'll put some videos into that demonstrate the scanning, the positioning of the patient for scanning. But yeah, I mean, in essence, that's what you're doing. But as I said, for more complex pathologies, or for pathology, or for patients who may be, there could be diabetic patients who are missing toes or whatever for whatever reason, and the anatomy is a bit more complex. Yeah, plaster of Paris might still be the most appropriate way to go.
Yeah.
I suppose there is, sometimes some podiatrists would be reluctant to scan the patient's foot, and it depends on levels of experience. Like we would have had quite experienced podiatrists who were kind of doubtful about whether just scanning the patient's foot and getting the patient to hold the foot in that position was the best way forward for customized foot orthosis. But over time, they become more familiar with it and they see the results of the devices that are manufactured using this method, and they seem to be pretty happy with it at the end. You know.
Okay.
Just from a pricing point of view, so the other thing that I wanted to say about this is we're reliant on this third-party scanning technology, the structure sensor. Retails for about between 400 and 450 pounds sterling, quite expensive. You're going to spend something similar on an iPad mini, another 400 quid. So you're up there on 800 quid, which does sound expensive. Over time, it pays for itself because you're not paying for as much plaster of Paris or foam boxes, and you don't need space to store your foam boxes and plaster, etc. But ultimately, and quite soon, I think we will not be reliant on the structure sensor third-party piece of hardware to scan. We anticipate that Apple will have LiDAR scanning technology, 3D scanning technology built into the iPad, which will make the external scanner redundant, which is good news. It's good news for your pocket because you want to buy it, and there's just less chance for things going wrong because there's just less variables. You're just relying on the iPad to do the scanning. So again, so thank you very much to everybody who attended this morning, this afternoon. It's really great for us anyway to be able to introduce you to the MSK side of things and the manufacture of orthotic devices. And on that note, Sorcha has just put the link to our contact form back into the chat. If you haven't done that, just give it a click, put in your name, email address, so we can follow up with you after this with the recording of the session. And we'll put in some other bits and pieces like links to the videos around positioning the foot and our follow-up survey. Otherwise, thank you very much. It's been a pleasure to talk to you, and on behalf of myself, James, and Sorcha.
Thanks, guys. Thanks, everyone, for listening.
Yeah,
Hope
we'll talk to you soon.
you got something out of it. Thanks a million.
Take care. Bye-bye.
Thank you.
Thanks, guys. Take care.
Bye.